To gain a greater insight and understanding of what the role of minimally invasive surgery is in dealing with spinal surgery, we decided to visit with Dr. Mitchell Levine at North Shore University Hospital. You know, medical technology has now developed to a point that smaller incisions and specially developed instrumentation now make it possible to return patients to normal lifestyle in a very short period of time. And by the way, we also met a patient who had undergone this surgery after having been literally incapacitated, and she was unable to walk or move without excruciating pain. So our guest today on Medical Update is Dr. Mitchell Levine, Chief of Neuro-Spine Surgery at North Shore University Hospital. How common is back pain?
It's actually the most common reason why people visit their doctors. Back pain itself is the most common complaint, and it's the most common reason why people miss time from work.
Many people suffer with back pain. So when does it require medical attention?
When it's interfering with their lifestyle, with the amount of time that they spend at work, with their ability to participate in their leisure activities.
Is there a difference between treatment between the young and the old?
Generally, younger patients with back pain may have back pain related to muscular injuries or some of the supporting structures, ligaments of the spine itself, whereas older patients generally tend to have pain from the bones themselves, a type of arthritis of the spine. Younger patients tend to have more muscular type injuries.
Well, how do you make a decision? Who do you go to see first?
Most people see their primary care physician as a first doctor.
And then he refers them to whom?
He may refer you to no one. He may treat you himself.
What type of treatment is called for then?
Most patients with back pain are treated with very simple remedies, rest, painkillers, some type of anti-inflammatory medications, some type of local treatments such as heating pads and ice packs and things of that sort. And the huge majority of those patients get better in a very short period of time. Don't require any complicated therapy.
Well, what if the pain keeps coming back?
Well, if the pain is persistent, doesn't respond to simple remedies, and is associated with other symptoms, such as sciatica, pain which goes down the leg itself and travels from the back into one of the extremities, then we tend to think that the patient requires another level of diagnosis first. We have to figure out what's wrong with them before we can decide what to do for them. So we generally send them for some type of imaging procedure.
X-rays?
Generally X-rays and either CAT scans or MRI scans.
When you look at the X-rays or the CAT scans, how do you make a decision? Can you tell when to do surgery, for example?
Well, the most important thing is the patient himself, to decide if the patient's signs and symptoms, what they're complaining of and how it's affecting them, justifies any invasive treatment. We then try and correlate that with what we're looking at on the MRI scans to see if their pain and their situation correlates perfectly well with what we're finding on the imaging studies, on the MRI particularly.
When there is pain, what's happening?
Well, there's two ways that you can experience pain from your spine. First of all, the spine is a bone, just like every other bone. And all bones, if this is a neck bone, this is the lower back bone, just like your arm or your knee or any other bone and joint, it can hurt. You could have pain from the spine itself. Any of these structures can cause pain. You can have damage to the joints which hold the spine together. You can have damage to the joints and ligaments which are along the back of the spine. And those types of problems generally cause back pain itself, pain in the spine itself, particularly when the discs which are these sort of shock absorbers between the bones. When they degenerate, when they dry out, when they no longer function like shock absorbers, they can cause pain because they have nerves in them. And when they become diseased, in this case diseased meaning dried out and just not functioning well, they don't do much for you other than act as a source of pain. That kind of pain is differentiated from pain from nerve compression, because in addition to being a bone, the spine acts as the house for your nervous system. Inside the center of the spine are all your nerves, which go to all your muscles. When those nerves are compressed, you get what's commonly referred to as a pinched nerve. You will get pain not necessarily in your back, but you can feel pain in the distribution of the nerve, where the nerve is going.
So they can have pain in the legs, and it shows itself in the lower back.
Not in the back itself. Or typically patients that have herniated discs and pinched nerves feel the pain down the leg more severely than they feel the pain in their back itself. And that's one of the ways we differentiate between someone who may require a surgical procedure or some type of treatment to remove the pressure on the nerve if the leg pain is the predominant symptom. That sets off a light bulb in our brains to think that this patient has a compressed nerve, which is different than someone who is just experiencing pain in the back itself.
All right, you've established now, for example, that it's something to do with the spine and you've got to resort to surgery. This is as a neurosurgeon, this is your decision. How do you go about that?
First of all, it's generally our approach to be extremely conservative, meaning we try to avoid surgery. Surgery is always the most invasive treatment that we have available, and it's an irreversible treatment. So we don't go ahead and do the surgery as a first step. So as you said, we have a series of things we tend to do with the patients first. The first thing is to wait a bit. 50% of patients after 6 weeks will have resolution of their pain.
Goes away by itself?
Goes away by itself, basically by itself. If you just wait that 6 weeks, limit your activities, rest, take some over-the-counter anti-inflammatories for the most part, 50% of the patients experience a remarkable degree of improvement. So a patient that's only had pain for a short period of time will rarely be a candidate for surgery. We tend to wait 6 weeks at minimum, unless the patient has some other symptom or sign which would force us to operate early, such as weakness or paralysis of one of the limbs. That's a different type of patient. Obviously, that patient requires emergency surgery. But for the average patient that only has pain, it's perfectly safe to wait, if the patient could tolerate the pain and be made comfortable in the interim.
Has there been a great difference between the way surgery is performed today versus maybe 20 years ago?
Well, when disc surgery was actually discovered around World War II, we used to do very large incisions, big operations, because primarily we did not have the imaging that we have today. We really didn't know exactly where the problem was. So part of the procedure involved looking around. We used to have to open up the whole spine, look at all the different levels, try and find during the surgery exactly where the problem was, and then fix it. As our imaging capabilities improved, we were able to localize with greater and greater detail exactly where the problem is. Once we developed CAT scans and now MRIs, we're able to know with extreme precision exactly where the problem is and focus our surgeries just on that one area. This has allowed us to take a procedure which used to have a 6 or 8 inch incision and a 2 or 3 week hospitalization to a procedure which has a 1 inch incision and an outpatient or overnight stay only.
Now you have a lot of instrumentation here on the table. How do you use all this material?
Well, the most common procedure that we actually do is what we would refer to as a laminectomy discectomy, which means in simple terms where we are removing the pressure on a pinched nerve.
In other words, the nerve that runs right up through...
The nerve that comes out of this little hole in the spine here. The nerves are in this little canal, and they come out of these little holes. And at each one of these levels, there's a disc, and the disc can protrude and push on the nerve at each of those levels. So, the simplest or most common operation we do is a discectomy laminectomy.
Which means what?
Which means that we take a little piece of bone, and we expose the nerve, and we take out the piece of disc that's pressing on the nerve.
All right, and to do that?
We now do that through what's called a minimally invasive technique, which involves these dilators, which spread apart the muscle itself rather than cutting the muscle.
Now, you're doing all this through a very tiny...
We make a tiny incision. We make an incision large enough to accommodate this tube.
This tube here.
The diameter of this tube. And we have tubes of varying diameters depending on exactly what we have to accomplish on that patient or how large the patient is. But generally, we work through the smallest possible tube, which is about 1 inch. The largest tubes we have are 26 millimeters, which is 1 inch.
Okay.
Most of the tubes are smaller than that.
And you do this all through...
We make a little incision in the skin.
Yeah.
Then we make a little incision over the muscle. Then we insert these tubes, which dilate. We put them down, and we put different sizes, one after another, until eventually we're able to insert this tube over that. We then remove the dilators, and we work through the microscope, through these tubes, and do our surgery through this little aperture.
Take us through some of these steps, Doctor.
Okay, this is an example of a more extensive procedure which involves a spine reconstruction. Some patients have pain both from nerve compression and from diseases of the disc themselves. They have a lot of back pain. Not only do they have leg pain or sciatica, but they have an intractable backache. Those patients require a fusion operation. And what we are able to accomplish is a complete spine reconstruction performed minimally invasively.
When you say minimally invasive, what exactly do you mean?
What we use are these this hardware to hold the spine in place while the fusion is occurring between the two vertebral bodies where the discs used to be. So this is like an internal cast.
And you're saying that the bone then grows back together?
Yes, because it is thought that a major source of pain in these patients is the movement of the spine around this diseased disc. And we know from many years of experience and scientific studies that if you fuse the painful disc, in other words, remove it and allow bone to grow across it and obliterate the disc and obliterate any movement across that disc, the pain is markedly improved.
Does this affect their ability to move?
No, not at all, because the spine is segmented with many segments, more than 30 segments, and each segment moves just a tiny little bit. In addition, the level that we're fusing is broken. It's not doing its job anymore. It's not moving the way it should. It's not allowing the patient to be flexible. It's only causing pain. So by taking that diseased disc out and fusing it, you're not affecting the movement or the ability of the spine to carry out its function at all.
Is there a limitation as far as the age is concerned?
The only limitation is the ability of the patient to undergo an operative procedure under general anesthesia for about 3 hours.
All right. Why don't we show the audience some of the animation here on the screen? Let me turn this machine on for you, and you take us through this on a play-by-play.
Okay, this animation is really showing us very nicely a representation of the nerve, that the pain going down the leg is originating up in the back, where the nerve starts.
And you can, how do you tell that? How do you know that the pain is originating in the leg?
Well, as I said, talking to the patient, getting their history, their symptoms, and making sure that the history and symptoms are consistent with that diagnosis, and also the physical findings when we examine them, that they have the proper physical findings.
Now, the patient is on his stomach, I guess.
We operate on the patient on the stomach, and here we're looking at how the incision would be made. We're looking at a back.
Now, do you cut the muscles when you go down there? There are muscles.
We split the muscles. We basically insert, like you're seeing here, these progressively wider tubes or rods.
Yeah, and that all happens to be in less than 1 inch.
Oh, yeah, much less than 1 inch.
And you're looking through a microscope, and you're doing what?
Once we have this in place, once we have the tube in place, which is our retractor, actually what we're looking through, we remove the dilators, and we then are able to visualize the anatomy. This is a light source that they're putting down, And you can then see down the hole, and we're looking at the anatomy we want to operate upon. Here the animation is showing the surgeon removing a little bit of bone. That's a little tiny piece of bone that we need to take out, and to open up the coverings of the spine to visualize the nerve and the piece of disc that's pressing on it.
Now, are there any blood vessels in that area that you might cut?
So just like every place else in the body, there are veins, there are arteries, and as you can see here, there's
one right
there's
there.
a little vein that the surgeon's going to electrically coagulate and cut, so it's not won't bleed during the surgery. He's moving the nerve root out of the way. Patients frequently ask, "Are you going to touch my nerve?"
Right.
And I always say, "Yes, we're absolutely going to touch your nerve,
You're
but
gonna
we're going to
push
do
it
it." We're going to do it in this very careful way, under direct vision, so it's completely safe. Nerves are very tough, and you can move them around without any risk of injury.
All right. Now,
And here the surgeon has removed a fragment of the disc that was pressing on the nerve, and after the procedure is completed, they're going to take this tube out and close the skin.
after the surgery, are these patients inhibited from any kind of activity?
They still have had an operation, so we advise them to limit any strenuous activities. They could do their normal sedentary type activities. They can go out to dinner. They can go to a movie. But generally, they don't drive or work for about a week.
Well, Dr. Levine, you just did some surgery, back surgery on a patient, and we met her here today at North Shore University Hospital. So we'll take a break and we'll introduce her to our audience. Stay with us. We'll be right back.
Global warming. Some say irreversible consequences are 30 years away. 30 years? That won't affect me.
We also met a patient who had undergone this surgery after having been literally incapacitated, and she was unable to walk or move without excruciating pain. You just had the operation recently, didn't you?
6 weeks ago.
And you're up and around walking with a cane?
Yes, I'm doing very well.
Before the surgery, what was it like?
Before the surgery, I couldn't sit, stand, or walk. I was lying down, incapacitated, really, for about 2 months.
Did it suddenly happen, or was something that grew?
Over a period of about 5 months, the pain grew progressively worse, and that's why I had the surgery.
Did you try other remedies first?
Yes, I had physical therapy, I had pain management, I was taking Vicodin every 2 to 3 hours, which was not touching the pain. And my quality of life was terrible. So I decided to have the surgery.
Now, when you had the surgery, what was that experience like?
The surgery went very well. I had it on one morning, and the next morning I was up, walking. I had no pain at all. And it went very, very well.
Well, you say you were walking, but you used a cane or?
Originally, I was on a quad cane, and then I advanced to a straight cane.
Okay, and now what's happening to you?
Now I'm walking with the cane sometimes. I can walk without the cane, so I am progressing. I'm looking forward to walking without the cane and returning to work in January.
And your work is?
I am a registered nurse.
So you really have to be moving around a good deal.
Yes.
Will you be taking any kind of medication? What's it look like down the road to you?
Well, now I take an occasional Advil. Other than that, I'm not taking any medications for the pain.
So, assuming that I'm out there in the audience and I hear this story and I've got back pain, what would you advise people to do?
Well, I would advise them to go through a course of physical therapy or whatever, but if they're having terrible pain like I was having, I would advise the surgery, because you can feel much better within 1 day.
Now, you have a professional background. You're a nurse, and you have a little more knowledge than the average person. People are frightened of this kind of approach when you say you need back surgery?
Oh, definitely. Definitely. I was afraid of having back surgery, but I did my homework. And this is the best type of surgery because it's not long and drawn out. The surgery is quick, and the recovery is much quicker than the average laminectomy. So I would recommend it very highly.
This patient had a discectomy.
Yes, she had a minimally invasive discectomy.
And now it means for her several months of just rehabilitation, just building up the muscles, and she's back in shape.
Basically, most patients sort of heal themselves. They just gradually increase their activities such that at about 3 months after the surgery, they're back to their normal activity.
Now, will she require any future treatment?
Probably not. So 95% of patients that undergo this procedure have just this procedure and require no further care for this problem.
Stay with us. We'll be right back.
It's never too early to start reading to your kids.
Are you prepared for what awaits you?
There are amazing possibilities when you open a child's mind to reading. Log on to the Library of Congress website and let the journey begin.
Tick, 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 tick. Massive heat waves.
Heat waves.
Tick. Severe droughts.
Tick, tick.
Tick, tick, tick.
Devastating hurricanes.
Tick, tick, tick,
Tick, tick, tick,
tick. Our future is up to you.
tick.
Go to fightglobalwarming.com while there's still time.
In medicine, each year there's a new advance. So in this area of neurosurgery, what's new?
There are really two major advances in spine surgery. One, I alluded to already, which was imaging. We have extremely accurate intraoperative imaging right now, such that we no longer have to look with our eyes to see inside the body. We could place devices, we could operate without actually opening the patient up. In addition to standard X-ray equipment, we have computerized X-ray equipment in the operating room, such that by looking on TV screens and computer images, we can see exactly where we're navigating inside the patient's body in a very minimally invasive way. In other words, minimal access, but allows us, this imaging allows us to do very complete operations with a minimal approach.
Now, you've brought a lot of this hardware here on the table.
Correct.
I think it's a little scary when you look at this, but this gives you the what? The flexibility, the accuracy?
This is an ingenious device, in my opinion, whereby once we have the screws in place in the spine, which is done by our computerized X-ray imaging, we then connect the screws to this very simple device, which acts basically like a wheel. And this little rod is attached initially to the end of this wheel, and just by rotating it through its arc, we're able to place this rod into the screws and secure the whole system.
Now, this is all by watching the
fluoroscopy, by the X-rays, the computerized X-ray systems.
It's as an ongoing way. You're looking up at a screen.
Yes.
And you're doing this.
Correct.
Beneath the
because
skin.
This is all under the skin.
Yeah, which is quite amazing.
We're not looking at this. We don't see any of this directly.
You're seeing it up on the screen.
We're looking on the screen.
Well, Dr. Levine, if there are problems all along these various areas of the spine, can you repeat this procedure, or do you do it all at once?
We can do this kind of minimally invasive technique for up to 2 discs.
Okay.
We could fix 2. We have the technology at this point to do 2. 95% of the patients require this procedure.
And after this, there is no disability?
Yes. No, this is the purpose of this procedure is to return someone to their pre-injury or pre-incident lifestyle. We want them to go back and do everything they did before without restriction. No restriction. To us, a successful outcome is not someone who doesn't do half of the things they want to do because of pain. A successful outcome is someone who's doing everything they want to do without pain.
Dr. Levine, in this area of surgery, is there any new research, new developments being made?
In the cervical spine, this is an example of a plate that absorbs. Instead of putting a metal plate, of course, and screwing it in, we put in this hydrosorb plate, which will stay for about a year and then disappear.
Oh, will stay long enough for that bone to heal?
Right, and then it disappears.
How lovely that would be.
That's what we're working
on. Well, that's happened with sutures. You used to have the
that's
sutures,
right.
now they
that's
all
right.
get absorbed.
Absorbable technologies and biologicals. In other words, in order to promote a fusion, we used to put bone in. Either the patient's bone, which was a painful process of taking their bone, or taking from a bone donor, which has its own issues. By using biological chemicals, we take a chemical which is produced biologically from a pharmaceutical manufacturer. We put that into these little absorbable cages, and in a period of 3 or 4 months, that chemical, which is exactly the same chemical that's naturally produced in our body, induces the bone to grow and forms a fusion.
Dr. Levine, thank you so much for letting us come and visit you here at the hospital. It's been a wonderful experience.
Thank you.
And thank you for joining us. We'll see you again next week.